and then we'll get started. Okay, colleagues, good morning, good afternoon, good evening. I would like to welcome you to the second meeting of the Global Coalition to Address Synthetic Drug Threats. My name is Brian Morales from the U.S. Department of State. And beginning this month of November through February, we will be looking at specific initiatives available to us through the international organization partners. We will also explore new activities or policies that we can initiate. In January and February, we will be having a full menu of activities available for review, and we will invite you to express your interest to the international organizations in terms of participating in the various initiatives. I have a few other administrative announcements. Please update your screen name so it lists your name, your organization, and country. And I also want to thank you for your feedback regarding the number of calendar invites. We recognize that we've been sending many calendar invites to participants over the past months, one per hour. And so to streamline that for future meetings, we are going to just send one calendar invite for the entire block of 3 hours for sub-working groups 3. And then we'll send one 4-hour block for sub-working groups 1.1 through 2.2. We'll still send the meetings for East and West, but you're free to choose which one of those you would like to attend. We are also seeking to continue to increase participation in the coalition to include stakeholders from all audiences of synthetic drug issues. So, for example, for this sub-working group, you might have public health entities, you might have some that come from ministries of social development and women's affairs and others. So please do distribute the registration link so that others can also participate in the meetings. I also want to share that the coalition website has finally launched. You can find it at www.globalcoalition.us. I'm going to ask Bill McClin to put that in the chat for us, and also to put the agenda for today's session. And so let me just put the slide here. For today's session, we've got our co-chairs, Dr. Riza Sarasvita, Deputy Director from BNN Indonesia, and Dr. Yutan Palsing Palhara, the Professor of Psychiatry from All India Institute of Medical Sciences, and they are our co-chairs. We will have presentations this month that will focus primarily on harm reduction, the next month treatment, and then recovery the following month. So today's we'll look at harm reduction from an HIV focus, the SOS initiative, and then we'll also be looking at some universal curriculum training. So with that, I'm going to turn it over to our co-chairs and stop sharing my screen. I didn't see Dr. Riza in the list of participants. I'm not sure if she has arrived since I began, but if not, I'll turn it over to Dr. Yutan to get us started.
Thank you, Brian, and a very warm welcome to all of you. And I extend my thanks as well for all of you to be offering your support and continuing with this process, this very important initiative. As Brian has very kindly introduced the theme for today's session, we are talking primarily about harm reduction. And when we talk about substance use and substance use disorders and even synthetic drugs, it's quite relevant for that as well, that it's not only the treatment that is important. We have to focus on so many other dimensions related to substance use that can have a very important impact on outcome of not just the substance use for the person, but for the family and community as well. We have a very rich agenda for today's session. We have 3 presentations. Also, we'll get to watch a video on an harm reduction focused intervention. The first presentation is titled Harm Reduction with a particular focus on HIV and AIDS prevention treatment among people who use synthetic drugs. It will be presented jointly by Ms. Giovanna, who is Chief UNODC, and Ms. Monica on behalf of Ms. Soltani, who is Chief UNODC HIV/AIDS section and Global Coordinator for HIV/AIDS recording. So can I request Ms. Giovanna and Ms. Monica to start the presentation, please?
Thank you so much, Nicola and Yuri, dear co-chairs, distinguished participants, dear friends and colleagues. Thank you for giving UNODC the opportunity to present some of the tools that we have created and that are at the disposal of all the international community to improve all the services that are necessary to protect, first of all, the health of people who use drugs and people with drug use disorders, and then to improve it, and then, of course, to support, if they so wish, their recovery. You will hear from some of my colleagues, but for me, I would like to use just a minute of your time to stress how UNODC can support member states in improving all of these services, from the most low thresholds of outreach to opioid agonist maintenance, from psychosocial therapies to therapeutic communities and recovery management. In short, from harm reduction, including on overdose, HIV, hepatitis C, to treatment, to recovery support. And some of our member states do not feel comfortable with some of these terms, but please do rest assured that evidence-based practice covering all this continuum of services is supported by our guidance document, including the UNODC WHO international standards for the treatment of drug use disorders that you see on screen, as well as by the mandates and the commitments of our member states, such as the outcome document of the 2016 special session of the United Nations General Assemblies and many other resolutions. And with this, having given you maybe a bit of a framework, I'm very delighted to give the floor to my dear colleague Monica from the HIV/AIDS section, who represents our global coordinator on HIV/AIDS and the chief of the section, Dr. Fariba Soltani. And she will zero in on services, particularly focusing on prevention, treatment, and care of HIV/AIDS and other infectious comorbidities. Dear Monica, please do take over.
Well, so thank you for inviting me to present today. My name is Monica Giupagia. I'm the global thematic focal point for drug use and HIV in the UNODC HIV team. And as you know, UNODC is one of the co-sponsors of the UN Joint Program on HIV and AIDS, and is the agency that is mandated to work on HIV prevention, treatment, and care among people who use drugs and people in prison. So the topic of today actually is something that we are working on for quite a while. Because it's obvious that the use of new psychoactive substances, the use of stimulants is spreading rapidly, and as many studies show, it's very closely linked with scaling up the number of people who are getting HIV or hepatitis due to the unprotected use of these substances. So what we did as a first step was to develop this technical guide on HIV prevention, treatment, care, and support for people who use stimulant drugs. And this guide is looking at three substances that are closely linked with the spread of HIV and the hepatitis, meaning amphetamine-type stimulants, cocaine, and new psychoactive substances. In my presentation today, I will focus more on the work that we are doing on new psychoactive substances, but just to tell you that, this guide that you see on your screen and that is available on our website is supported by a capacity building program with trainings available online or in person. And so far, we reached around 12 countries mostly affected by the use of stimulants with this training and train a couple of thousands of people so far, mainly service providers, community representative of community-led organizations, and decision makers. So the same training was available, the same capacity building program was available in Eastern Europe and Central Asia, because this region is unique when it comes to synthetic drugs. Synthetic cations are very much spread in this region. The injecting is rising rapidly, and also the way people are, especially after COVID lockdowns, the way people are accessing these drugs, it's more different than what we've seen so far, meaning, accessing via internet. So first we did needs assessment in 6 countries in the region: Moldova, Ukraine, Belarus, Kazakhstan, and Uzbekistan, focusing on, what are the trends of use, what are the needs, what are people identifying as their main barriers and as the main needs. And again, these publications are available on our website on UNODC. The results of this need assessment show that among people who are using, there are a lot of gaps in knowledge and understanding of the health risks. Then it showed that for the service provider, including the health service provider, there is a lot of need for capacity building and for understanding the phenomenon. And then also in data collection, there are a lot of gaps and needs for improvement. And very often in this needs assessment, the issue of mental health services, the mental health issues that people who are using new psychoactive substances are facing and that are not looked in, and they will not receive support. Based on the needs assessment, following the way people are procuring the substances, it came out the need for to do web outreach and to improve the technologies to provide more services for people who use new psychoactive substances and stimulants. And that's why it was developed an electronic guide for HIV harm reduction interventions, an animated learning video explaining the harm reduction services, and recommendations for web outreach. And through this program, you can see here on this slide that we managed to reach a very large number of people. Almost 3,000 between 2001 and 2002 reached out for online consultations. 1,690 over received information and were referred to testing on HIV and hepatitis and sexual transmitted interventions, sexual transmitted diseases. And out of this, 155 tested positive for HIV, 38 tested positive for hepatitis, and 65 for sexual transmitted diseases. So, so this is in a nutshell, the technical guidance, the capacity building program, the concrete interventions with web outreach. And for the next steps, we are working, while we are continuing the capacity building, both for community-led organization, for medical staff, for people working on web outreach, and for professionals, health professionals who are working on mental health disorders. We are also working to support the community mobilization. And the last but not least, to look for resources to fund tailor-made harm reduction intervention for people who use non-psychoactive substances, as these interventions are very much underfunded in Eastern Europe and Central Asia, but also in other parts of the world. Thank you very much.
That completes the video.
Thank you so much. I again thank Ms. Monica for that very interesting presentation that kind of highlights the importance of focusing on HIV targeted interventions. HIV continues to be a global concern, and people who use substances, they remain one of the most high-risk groups. This presentation also kind of highlights the need to have a comprehensive package in terms of not just making the services available, but also ensuring that people who are expected to deliver these services, they are trained in delivery.
I think, Yatan, your screen has frozen. Let's give him a minute to get back. Well, while we are waiting for him to return, maybe we can move on to the next presentation. And that is the Stop-Overdose-Safely initiative.
Yep.
You're back, Yatan, I see
Okay.
you. Thank you so much. Go ahead, please.
So we do have Ms. Giovanna with us in this session, and probably we'll come back to her once we have the other presentations. We now move on to the second presentation for this session. We all know overdose is a major concern and is one of the leading cause of premature mortality among people who use substances, primarily by injecting route. We have a presentation from Ms. Anja Busse. She is Program Officer, UNODC. She'll be talking about this initiative SOS, Stop Overdose Safely, by UNODC. Ms. Anja, please.
Thank you so much for the possibility to present to you the UNODC WHO Stop Overdose Safely initiative, the lessons we have learned, the plans ahead, and of course the possibilities to join. You have heard several times that we are estimating around 60 million people worldwide have used an opioid in the past year, and that includes, of course, synthetic opioids. And about 500,000 lives are lost on an annual basis due to drug use, to which opioid overdose is an important contributor. At the global level, 2/3 of direct drug-related deaths are due to opioids, and in some sub-regions, the proportion can be as high as 3/4 of such deaths. The CND Resolution 55/7, the Commission on Narcotic Drug in 2012, gave a mandate to promote measures to prevent drug overdose, in particular opioid overdose, and has asked all member states to include elements for the prevention and treatment of overdose in their national drug policies and to share best practices and information around overdose management, including the use of naloxone. CND Resolution 55/7 also requested UNODC in collaboration with WHO to include initiatives to prevent mortality from drug overdose, in particular overdose, as part of our demand reduction programming, which we then have done with the SOS initiative. All of this has been further strengthened by the ANGA's 2016 outcome document that said how the promotion of national drug policies of prevention and treatment of drug overdose, in particular opioid overdose, and the use of the opioid receptor antagonist naloxone to reduce drug-related mortality would be of high importance. In 2014, then WHO issued guidelines on community management of opioid overdose that include as a first recommendation that people likely to witness an opioid overdose should have access to naloxone and be instructed in its administration to enable them to use it for the emergency management of suspected opioid overdose. And then UNODC and WHO launched the SOS initiative with the goal that 90% of people likely to witness an overdose should be trained, 90% of those trained should be supplied with naloxone, and 90% of those supplied with naloxone should also carry it with them to respond in case of a suspected overdose. The SOS study with which we have demonstrated all of this took place from 2016 to 2021 in Central Asia and Eastern Europe. And here you can see some of the results. With a good level of preparation, in only 6 months, we have trained over 14,000 people likely to witness an overdose, disseminated 34,000 ampules of naloxone, and 90% of the project's participants recorded using naloxone and witnessed overdoses. So we have also reached our 90-90-90 targets and demonstrated their feasibility. As also in almost all instances, further, the victim was reported to have survived. So estimations suggest that in the project, around 4,000 naloxone uses took place in only 6 months, and we estimate a high number of lives saved. Also note that with this, we have demonstrated that take-home naloxone schemes are feasible and save lives in lower middle-income countries where before systematic evidence of this was lacking. So some of the lessons we have learned to share here with you was the strengths of 2 UN agencies, UNODC and WHO, working together. And there was a paramount role of involving national authorities early and engage them and have their buy-in. Other kind of parts were also important, like the consideration of the legal context, the availability of naloxone, a training cascade going down to very short and simple to deliver overdose trainings, and a mapping of drug treatment services for further linkages to additional support, for example. So now, if you want to join the SOS initiative, be informed that we do have training materials and a capacity building strategy ready to share and implement and work with you. We also have available the specifications of an SOS naloxone community kit that obviously can be adapted further, including depending on what type of naloxone formulation is available. And we do have assessment tools to prepare and understand the situation at the beginning, as well as an implementation study protocol for further data collection, monitoring, and evaluation. So our future plans include going from SOS, Stop Overdose Safely, to SOS for Life in this area of opioid overdose prevention. We want to implement, and we hope on your interest and support, the SOS for Life initiative in other countries. It's really a very doable way to save a lot of lives in short time. Furthermore, we want to include aspects with a view to the criminal justice system, to substance use in humanitarian settings, and to settings with high synthetic opioid prevalence further in the SOS toolkit. We will also include the SOS considerations in the implementation tool for the international standards for the treatment of drug use disorders, and updates, including on synthetic opioids, will make it when WHO is now updating different guidelines related to opioid use and opioid use disorder treatment. And last not least, the SOS for Life will extend SOS in terms of more comprehensive responses across the board. So this one we will not have time for. This is a film about life, which we recommend you to see here at this YouTube link. It demonstrates and showcases the importance of saving lives through effective treatment and emergency responses, including in low middle income countries. So please do join us, join the SOS for Life initiative. Here you find my contact details and the contact details of our colleague Dimitri from the World Health Organization. With that, thank you very much, and hope to talk to you soon.
Thank you, Ms. Anja, for sharing this success story. Naloxone happens to be one of the most effective evidence-based intervention to prevent and avoid overdose-related deaths. And this study from UNODC and WHO kind of emphasizes the importance of incorporating naloxone as one of the key strategies towards harm reduction, especially in those parts of the world where opioid-based substances are one of the commonest used substances. We now move on to the next presentation. I believe there is no video as was suggested earlier. So
a video is going to be available and we are ready to play the video on your cue.
Okay, sure. So let's watch this video first and then we'll move on to the next presentation. Thank you.
This is a film about life, about hope, of actions that make a difference, and it's about our future. It's also a story about people who help change lives, people who help save lives. And it's also about remembering, not forgetting. Remember the 500,000 mothers, fathers, sons and daughters who lose their lives to drug use every year.
It's not something that Jonathan did or didn't do. He was the son that any mother would have wanted her son to grow up to be. Unfortunately, we still don't know what makes someone vulnerable to develop addiction. He deserved to live a life like any of us. He would have been the kind of person that you would have interacted with in your daily basis and would not have thought twice that he had a problem, that he had this terrible, terrible disease. That's why his death was such a shock for our community, because he was a good person. He deserves a legacy, and I will make sure that he has that.
Each year, at least 115,000 people die from an opioid overdose. But we have the chance to reduce that figure. We have the chance to make a difference. And effective solutions already exist, most of which operate at the community level.
It doesn't just change an individual when you treat somebody with drug use. It changes a family, it changes a community. We have a team of outreach workers who go out to the community and identify these persons who have the need for methadone maintenance therapy, psychosocial support, and other interventions as per the assessment of their needs. Psychosocial intervention is quite a wide range, ranging from psychological services, social skills improvement, family integration, people who come when they are unkempt, they are dirty, they are homeless, they are malnourished, they come back and they restore their human dignity. It gives you job satisfaction because you go to work and you know you're going to change somebody's life.
This success story in Kenya is one of many community-based programs that is a cost-effective and high-impact solution. But there are many more successful initiatives happening all over the world.
Люди, когда приходят к нам, они привыкли к тому, что им никто не хочет помочь. И когда они видят принятие, поддержку и конкретную помощь здесь и сейчас, это очень подбадривает. Мы обучаем людей о том, что такое передозировка, то есть рассказываем, какие они бывают, какие симптомы, и как можно помочь человеку, если вы увидели передозировку, если стали свидетелем передозировки.
Тоже рассказываю про налоксон, чтобы он был в доступе, как им пользоваться, и чтобы избежать смертельных передозировок.
Наркозависимые люди, когда чувствуют принятие и поддержку, они готовы меняться сами и отдавать обществу тоже только хорошее.
People are helping people. Never has collaboration been more important. Ideas that have been approved at the highest level are working at local levels.
The SOS project, Stop-Overdose-Safely, is a really wonderful project. Within the project, we provided services to more than 5,000 people. We provided them with kits with naloxone and with unique training. We trained 5 master trainers and 54 national trainers who provided training to people who live with people who are under utmost risk of suffering from overdose. Without the support from WHO and UNODC, this project would be impossible.
Right now, we have an opportunity. an opportunity to realise that we can scale up overdose prevention activities. Today we can act to make a difference. Today we can help to break the stigma. Today we can stop thousands of unnecessary deaths. Drug dependence is not a choice. It never has been. It's a complex mental health condition and not a self-acquired bad habit. It can be prevented and properly addressed to improve life and well-being of people. It should be an integral part of primary health care and universal health coverage. Today, we invest. Tomorrow, we move forward.
Thank you. This video is again a very great advocacy and awareness raising tool and is freely available on YouTube. So if you are interested in sharing with your colleagues, please feel free to do so. This again highlights that while we have research that establishes that there are interventions that work, we also have now evidence that it's possible to implement these in real world situations. And this is being done in different settings across different regions. So there is no reason not to believe in the effectiveness and applicability of these interventions. We just need to find ways now to invest into these interventions and take it to the people who are in real need of these interventions. We now move on to our third presentation, and with us we have Mr. George Murimi. He is a program manager at Colombo Plan. He'll be sharing his thoughts on universal treatment curriculum. Mr. Murimi, please.
Warm greetings from my side. Just a minute.
And my apologies. Can we ask you to speak closer to the microphone, please, because you're very distant and very echoey right now.
All right. Warm greetings again to the dear participants and delegates in this particular coalition meeting. We want to thank you for the fact that you have come a second time. I think the first time we met was a month ago. So mine, ladies and gentlemen, is to give you a very short overview of the universal treatment curriculum, the UTC. And for us to be able to really appreciate what the UTC is, it's good for us to look at the genesis. Where did this thing begin? How did it come into play? So that we can be able to see what it is and maybe probably chart the way forward. And looking at some of the sources that have been put by INL, particularly the INL field guide, I think they have listed for us what we already know, that there's a lot of research that tells us what works in the treatment scenario. But the challenge has always been to translate that into practice. I think we also know that addiction is well misunderstood, greatly misunderstood, and that has led to tremendous devastations in families and individuals, just like our previous presenters have said. Now, the last bullet tells why INL came up with the idea of the universal treatment curriculum, which we call the UTC, is that, you know, there was need to be able to translate the science into something practical. And for that, they came up with the curriculum. And to do that, we are very glad to note that they brought in very qualified people from research, from the university, practitioners, to be able to put this science into a step-by-step process for addressing the issue. And having done that, the universal prevention treatment curriculum was developed around 2018, 2019. And the spirit was and has always been, and I'm quoting freely from a publication 2019, is that these materials need to be free and available to all. And I think that was INL's contribution to the world, just to be able to produce something that can be available to everybody and address the issue that was at hand. So the curriculum developers were largely from the US and from the Western Hemisphere. I think that INL was wise enough to make sure that these materials are piloted both in Asia and in Africa, to be able to make sure that they have that universal outlook. And I can see from the call, quite a number of people here were actually involved in the piloting. So, and I remember in 2019, having been working in Kenya in the treatment scenario, we had quite a number of trainings that we were carrying on. We had the universal, we had the therapeutic community trainings and a few other trainings that were happening. And quite a number of trainings that we were conducting in Kenya, we ourselves were having to develop our own training materials. So you can imagine we are developing our own training materials and we are working alongside. It was very stressful. But when we got the UTC, we immediately switched over to it. That was around 2019. And we were asked to justify why are we using the UTC and not any other. And we gave among the following points. These are things we wrote in 2019. And at the conclusion of my presentation, you'll see that has stood not only in Africa, but I think in Asia and other different parts of the world. First of all, is that it addresses a critical workforce development gap. Then, of course, it has been developed using a very participatory process. Then it utilizes well-trained and experienced trainers. And then thirdly, fourthly, it's an integration of evidence-based interventions. These were points we wrote in 2019. And you will see these were points written in 2009. But when you look at the end of my presentation, you'll see same points have been raised by my colleagues in the universities and other scenarios. Just to tell you that the UTC, among other things, has stood the test of time. That makes it extremely peculiar, makes it extremely exemplary. As we mentioned earlier on, the materials were piloted here in Asia, where I am, and also in Africa, where I was working at that particular point in time. And over a period of time, quite a number of materials have been developed, which were in treatment, and then UPC, and then universal recovery curriculum. The first set was a UPC basic level. And this is a very broad spectrum of issues that covers quite a number of issues that are used in the treatment scenario. And other than offering knowledge, the UTC basic series has that element of skills development, competency development, and that is unique in itself. It comes in 8 packages in 8 different courses. Now, over a period of time, we have discovered the secret of disseminating it probably two courses per time. And then after disseminating 2 courses, we give people a short period of about 2 months to go and implement in their practice and train others, and then they'll be able to come. So this happens probably over a period of about 1 year. Fortunately, we have been able to do this both virtually and on a face-to-face basis. Now, once you do the UTC basic, then you are eligible to sit the credentialing exam, after which then you can go into the advanced courses. Now, these ones are, as the name suggests, they are advanced, they are more theoretical, and they offer a wider scope of learning. They are 14 in number, and we have listed them therein. And they address probably very specific needs from pharmacology, to enhancing motivation, and a host of others, working with families, co-occurring disorders. They address very, very specific issues. It's certainly not practical to train in each of them. So we ask people to choose, or a country to be able to pick which is their area of need. Unlike the basic series will require you to sit the entire before you sit for credentialing. But for the advanced, then there's always the element of choice. Now, we have actually moved over to be able to address what science is telling us, that interventions also need to be tailored to specific clinical groups. For that reason, the UTC has also evolved into a new set of curriculum. One is for treatment of children. And I also need to indicate, other than the treatment for children, CICAD has also been very gracious to develop another one for treatment of adolescents. We also have another one that targets the treatment of women, the other one for criminal justice system, others for sexual orientation and gender, SWG, and then the other one that looks at treatment and prevention in the rural settings. Here is the universal recovery curriculum, which I think will be dealt with at a later on. But by and large, it comes again in two portions. One for people in recovery themselves, we call the peers, and other people who support them, whom we call the allies. Now, having said that, I asked some of my colleagues who have been interacting with these materials, particularly at the university level, including the honorable co-chairs here. So we asked them, why do you use the UTC at the university level? And some of the people in the government settings, why do you advocate for the UTC? And here are some of the comments that we got at a very authoritative level. First is the issue of involving interventions or experts, international experts, both in the curriculum development, in the review, and in the subsequent improvement of the materials. Secondly, issues of making sure that it is really based on the current research. And we know that research is evolving. You know, what happened in 2009 when UTC was happening, you know, a lot more has come. So we make sure that we incorporate that by very constant and regular reviews. In the fourth issue, we want to say that the UTC is universal, just as the name suggests. That means it is easily adaptable into any context. And we work in a whole range of contexts, from Latin America to Asia to Africa, you know, and every other part of the world. And so far, I can tell you without any doubt or without any contradiction, there has not been any country that has raised an issue against the UTC to tell us that it is culturally insensitive or inappropriate. So we want to say it is applicable, adaptable to any context. And meaning adaptability, it also lends itself very easily to translation into the different languages. So finally, what I got from my colleagues at the universities is that the core competence for addiction professionals, all the core competencies are actually incorporated into the UTC. So finally, I looked at UNESCO. I really was inquiring, what is it that constitutes what we might consider a quality curriculum? Then once we look at it, we want to ask ourselves, do we think that the UTC fits that criteria? And I can say again that in terms of the development, it was very planned, it was very systematic, it was very inclusive, it was very consultative, with quite a number of you here involved. It was led by curriculum professionals. It is actually cyclical in nature, and it is sustainable. So in terms of curriculum development, I think it meets the criteria for being a quality curriculum. Secondly, in terms of the curriculum itself, I think it has values that holds very dear to every client. The UNESCO materials actually talk about child, but in our case, we can talk about clients, we can talk about trainees and participants. Then it has high quality content. We cannot argue about that. It is well organized and structured, and then it is underpinned by a set of principles, you know, standards, the UNODC standards, the NIDA principles, and a host of other issues. So having put it against the UNESCO quality curriculum attributes, then I want to put it to you, ladies and gentlemen, that I think that the UTC is what we might call a quality curriculum. So we will be posting in the website, which has been shown earlier on, this booklet that outlines every of the courses and even provides the course descriptions and also the number of hours that we give for the trainings. So with those very few remarks, ladies and gentlemen, I wish to thank you for your very kind attention.